All right, everyone. It's 4:06 actually now. People continue to slowly trickle into the webinar. Thank you all for joining. Before I continue, just want to double check. Can you guys hear me? You can either respond or put something in the chat box. I just want to make sure you can see the screen and you guys can hear me.
Yes, we can hear you.
Fantastic. All right, my name is Jacob Kirsch. I'm a cardiothoracic radiologist in Florida, longtime member of NASCI, and just honored to be here with you for our Curious Cases webinar for the month of May, which is crazy to believe that we're in May already. Time is flying. Perfect. So, usually the way we do this, for those who have not been on a webinar before, is it's an open door policy. If any of you have any cases in your computers that you want to share with the team, either because they're very interesting, because you're getting a second opinion, or what have you, please feel free to do so. We encourage everybody's participation. So if you have a case, just let me know. You can just tell us using the microphone, or we just put the comment in the chat, and we'll do that. Give me 1 second, guys. Okay. Sorry about that. They wanted to start vacuuming my office here in the middle of the webinar. Anyway, so I'm going to start with a couple of cases. I have 3 cases to share with you, so definitely won't take the full hour. So hope that you guys have some cases to share with the team. And let me share a different screen then. All right, there we go. So now we're showing my icon viewer. So we're going to start with, I guess, this one. And again, guys, feel free to interrupt me, ask questions, etc. as we go, okay? We're just going to do it here. It's going to be easier. So this is a 78-year-old male. And he's part of a metastatic workup of abdominal cancer. So anything catches your attention there, guys? Any comments? I'm going to stop right there and see if anybody has any thoughts about what we're looking at.
So I didn't see exactly where it was coming from, but it looks like there's a vein coursing anterior to the heart coming off of the SVC.
Okay, very good. So basically, you're talking about this little structure here. I don't know if you can see my. Can you guys see my cursor or no on the screen?
Yes.
Okay, perfect. So you talk about the little structure there. So if that is correct, so every time you look at a chest CT, right, there's usually nothing to the left of the aortic arch. So when you see some structure there's a common differential that you go through. It can be either a left-sided SVC, it can be a partial anomalous pulmonary venous return. So when your lung venous drainage goes, instead of going to the left atrium, it goes into the brachiocephalic vein. And the third thing is usually could be a lymph node or adenopathy, right? And then of course lung cancer, I guess, but those will have a slightly different appearance. They're going to be more irregular or spiculated. And when you have contrast, lymph nodes will rarely enhance as much as the vascular structures that we described, such as the left-sided SVC or the PAPVR, or partial anomalous pulmonary venous return. What's interesting about this specific case, I've seen probably a handful already in my career. The first one I saw was as a fellow several years ago. So let's follow it. If this was a left-sided SVC, it would be coming off the brachiocephalic. That would be a normal origin. And as you follow it down, those almost always, not always, but almost always go all the way down around the heart and drain here by the coronary sinus. So basically creating the same physiology as a atrial septal defect would, the same type of shunting. But clearly this is not the case. If it was a PAPVR, it would be draining lung. So you would see the veins moving from the parenchyma, kind of coalescing and then draining up into the brachiocephalic. So you have a left upper lobe PAPVR, but that's not the case either in this case. So this is a vein that's communicating between the brachiocephalic, moving down, and actually draining into the left atrium as a pulmonary vein would. So this is a complete different entity. It's a remnant, an embryological remnant of the superior cardinal venous system. This is called in the literature as a levoatrial vein. And again, it's just a communication that goes from the brachiocephalic into the left atrium. And they almost always invariably look like that. So again, it's not very common, but potentially if you're doing a lot of thoracic imaging, you'll bump into them maybe at least once. And again, it's just an embryological remnant communicating the brachiocephalic with the left atrium. Again, a levoatrial vein. So there is a little bit of shunting here, right? Because the brachiocephalic should be draining into the SVC and the right atrium. And here's blood draining into the left atrium. So there is a little bit of shunting going on, but probably of no physiological significance in this patient. Any questions about this case? Have you guys seen one like this? Anything that you guys want to add? All right. Let's see the next one. Let's do this one. Patient with the 24-year-old female with a history of heart disease and cardiomyopathy with arrhythmias, already has an AICD in place. And you can look at the localizer. There's a device. We know that this defibrillator, because it has both a battery and a capacitor. And here, these thick parts of the wires, that's part of the capacitor. That's where the energy gets stored to defibrillate the patient. So it's not just a pacer. And again, very young female. So any comments? Let me know what you think as I scroll. What are the main findings, guys?
So the right ventricle is very large.
Yes, it is. Anything else? The right atrium is also a bit enlarged, right? And that can be a combination of factors. Number one, when your ventricle enlarges, your annulus kind of enlarge as well. So you're going to have poor coaptation of the leaflet. So you have immediately some tricuspid insufficiency. And the other thing is when you have leads going through the tricuspid orifice, they don't co-opt as well. So that also leads to some degree of insufficiency. So maybe the right atrium is a little bit large as well. The other thing that's kind of interesting here is look here at the septum. You see how low attenuation it is here and here also by the septum. And as I continue to move down, look, you see all that low attenuation here in the septal muscle. Let's look at the study without contrast that was done afterwards. And I think it's significantly more obvious there because we don't have the streak from the adjacent contrast, but there's just a lot of fatty replacement of the muscle wall. And if you look at the free wall of the RV, you can see how scalloped it looks as well. So again, we have a
Is
very
this
large
along the like
RV.
AR
Correct. So I'll give you more information on this patient. Yes, you got it. So this girl was diagnosed. She's got a she underwent some genetic analysis. She's got a DSG2 mutation, which plays a part in the muscle development. So this is a patient that has been highly associated. It's one of the mutations that have been associated the most with ARBD or ARVC. So based on all of the findings, she was diagnosed with arrhythmogenic right ventricular cardiomyopathy, like you said. So yeah, good call there on this patient. It's a pretty dramatic case. She is going to end up having a transplantation. So it's just, again, a very, very nice case. We used to see, oh man, almost 15 to 20 years ago, when it first was described, there was any patient with a large RV was sent for MRI to rule out the RVD, and we were just diagnosing it a little bit more than we should have. Some fibrofatty replacement of the myocardium is expected in normal individuals. There's plenty of literature out there to prove that. The older the individual, the more likely they're going to have some fatty replacement of the myocardium. So that is not part of the task force criteria on imaging for diagnosis of ARVC. So it's nice that we see it and we have all the other findings and we can kind of put it together. But otherwise, that fatty replacement on its own should not uh, make the diagnosis of ARVD. The large ventricle, the dyskinesis, yes, but again, those are just part of the task of the criteria that the task force created, and then you have to have other major or minor factors to be able to give the diagnosis of ARVC. So again, just an unfortunate 24-year-old girl, and again, getting listed for transplant. I see Dr. Denny just joined. Hey, Carl, how are you? And congratulations,
Hi there. Hi.
First president of the Canadian STR. Is that correct?
Well, yes, yes.
Yes.
Just finished.
Fantastic. Well, that's awesome. Congratulations.
Thank you.
All right. So
Thank you.
this is a 68-year-old male with a history of LAD distribution MI in the past. It's a little bit too bright. Let's make this a little bit window a little bit better. So presented to the ER with severe chest pain, and they did a CT scan as soon as they did a CT scan without contrast that I'm not showing. They thought the patient had a large, probably high attenuation pericardial effusion. They were thinking of tamponade, maybe hemopericardium. They took him to the cath lab, look at the coronaries, and then put an IABP. You can see the balloon pump there in the aorta. It's there's in place. But then they did CT with contrast afterwards, and I think we can see that what we thought was a large pneumopericardium on the non-enhanced CT is something slightly different. I'll tell you the story of what happened in the angiograms. The conventional angiography showed non-obstructive diffuse atherosclerotic plaque of the coronary. So yes, there was a lot of plaque, but nothing to explain the symptoms of the patient, nor the very poor ejection fraction of function. It was assessed at like 15% of presentation. So anybody wants to?
So it's like a apical aneurysm in the left ventricle.
Yeah, looks like a really ugly apical aneurysm. So would you say this true or false aneurysm?
Who we talked about this last month, but
Yes.
I mean the neck looks, I guess, narrow in certain portions, but then it's very large in the current slice you have. So I'm not entirely sure. I would favor true though.
Okay, very good. So let's look at the coronals and see what we think, some coronal recons. So there, it kind of looks like it could be true, but then you have like a second one here, second out pouching out of the true. It just looks really ugly, and maybe some thrombosis here from the original true. So patient did have a true aneurysm that ruptured, so he has a false on true or acute on chronic. I don't know how you want to. I think it's both, because one is a temporal definition, right? Acute on chronic. The other one is a type of rupture of the layers of the myocardium. So patient did have an old MI with really poor ejection fraction, and it seems like he had a second MI that eventually completed the damage and ruptured that true aneurysms, and that tamponated. So he has that false aneurysm on top of a true aneurysm. So has both. Patient was stabilized, was kept in house, and was prioritized for a heart transplant, which he got actually about 5 days after this. He was just here in the unit on all sorts of pressors and medications until the heart became available, and he was pretty lucky. So he's actually doing well now with a brand new heart in place. So again, a really uncommon case of false aneurysm on top of a true aneurysm, or a ruptured true aneurysm, I should say. So those are the 3 cases that I prepared for today. Anybody else on the call who wants to show a few cases? I see Dr. Denny, Dr. Agrawal, Julia all the way from Chile joining us. Hey, Julia, how are you?
Oh, hi, Jacobo. I'm doing well, but I didn't prepare any
No
case
worries.
today.
I was just saying hi. I wasn't putting you on the spot.
Hi, hi.
I've got a case, Jacobo,
Perfect.
but I'm kind of multitasking. I'm also presenting at endocarditis rounds on the other computer in a few minutes as soon as they get to that patient. So
You tell me. You want to start now,
um,
or you want to wait?
I don't think they're on that patient, so I think I'll go ahead.
All right, I'm making you a presenter. Let's hope your computer collaborates.
Yeah, yeah. Right now it's just okay. Oh no.
There you go. We can see your screen.
So listen, can someone go? I just heard my name called to go and present the
Fair
other
enough.
patient. So
No
can you take it back and I'll present after?
Prachi, you think you have cases?
I wanted to present the guy planned for Thursday, crocheting, because Carol had a look at it. I had second thoughts,
Let's see.
I've washed them away with the CT scan. I just wanted to be absolutely sure.
All right, Prachi, you are muted.
Jacobo, I actually don't have any case.
Okay.
I was reading cases, decided to log in.
No worries. All right. Anybody else on the call who wants to present a case?
Okay, I have a case. I might just need to get a second opinion if you don't mind.
No, we don't mind at all. I'm gonna make you present it. All right.
Okay.
How do you pronounce your first name? I don't wanna
Oz.
destroy it.
Yeah, my first name is Oz.
Oz? Okay, perfect. Thank you, Oz.
Yeah.
Where are you located?
So I'm a cardiothoracic radiologist at University of Missouri currently.
Perfect.
All right, let me share. All right. So this patient came to the hospital, and she's an 88-year-old female patient complaining of the chest pain. And they scanned the patient's CT chest to rule out PE. And what we found here, that hypodensity here in the septum, the mid-septum of the left ventricle. So we recommended to start with echocardiogram, or they can refer the patient to the MRI cardiac for further evaluation. So, they did echo, and they found a hyperechoric mass in the septum in the same area. And then we did MRI cardiac. So I didn't have the cine images, but we can see that peripherally hyperintense lesion in the septum, and there's a focal septal thickening in the mid ventricle. So this is short axis. You can see that asymmetric thickening, but it's more obvious on 4-chamber view. And on the late gadolinium enhancement, we see like an intense enhanced lesion in the mid septum, and it's pretty interesting. On short axis, it's similar intense homogeneous enhancements, kind of like spindle shape at the margins here. The left ventricular function is completely normal. There is no regional motion, wall motion abnormalities. There is no reduction in the ejection fraction. So everything else is normal. So this is kind of like an incidental findings. So they sent the patient for CT chest, abdomen, pelvis, to rule out a primary malignancy, and it was negative. Nothing in the CT chest, abdomen, pelvis. Patient had a recent MRI brain for some other reason and showed no any metastasis in the brain, no any primary as well. So I want you guys to, I want to hear like your suggestion about this case. What do you think this could be?
These are nice images, very interesting. I'm pretty sure your automated software to check cardiac function probably got really confused with which was the RV on the short axis and struggled with that. So I'll tell you what I think. Number one, so we have no history of cancer, correct? That
No.
that was established.
Yes, that's correct.
Where is the patient from?
So she's from Missouri.
She's okay, and ethnically, traveling back with family to Latin America, Southeast Asia.
Yeah, I don't know actually.
Okay. The one thing that that I can think of that I have seen that may look somewhat similar is a giant hydatid cyst, like a echinococal cyst of the heart. They can be like this, just one cystic structure. Rather, when you have them in the pericardium, they're multicystic. They look like a bunch of grapes. But when they're in the myocardium, the couple that I've seen and the ones that I've seen in literature, they can look like that. The CT was with contrast, correct? The one that you showed, because it was a P study and it was not enhancing on the CT.
It's not enhancing on CT. It's kind of like of like ill-defined. Actually, this is a post contrast images on the right side.
Okay. Yeah. So
those are contrast. So there's an intense enhancement there.
And again, remind me the gender and age of the patient.
88-year-old female.
80-year-old female, so an elderly female.
Yes.
Okay, because middle-aged women they get fibromas and they can be like this. It can be somewhat homogeneous in signal to myocardium and then enhance quite a bit because of the fibrotic component, and they look like focal enlargement. I think actually we showed a couple cases last time, I think, or 2 months ago. So it doesn't look great for that, but that potentially could be in the differential.
Yeah, that's what I was thinking about fibroma. Yeah. Could be metastasis. However, I mean, patient does not have any known primary malignancy, but I was thinking, it was like helpful because I already had CT chest and CT abdomen and pelvis and showed nothing actually.
Okay.
So yeah, I wasn't sure like if it could be like metastasis. Can I put metastasis in the differential?
It could be, yeah, until proven otherwise, right? Mets are supposed to be the most common malignant lesions in the
That's right.
The heart, in the heart, based on the pathology literature. So yeah, you have to keep that in your differential. Anybody else has any comments? We lost you. Okay, somebody started talking, but then we lost you guys, so you went on mute.
Yeah.
I'm back.
There
It's
you
Carol.
go. Hey, Carol. All right, so fantastic. You're gonna solve this for us, Carol. What do you think this might be? Did you hear the presentation?
Oh my God. I didn't hear anything. No. No, I was.
80-year-old female presented for PE. They saw this on the CT scan, that hypodensity in the thickening on the septum. They did an echo, which showed it to be hyperechoic, preserved DF and function, and now they did an MR. And I threw in a differential, which included, of course, Mets, but the patient has no history of malignancy. And then I thought maybe a giant hydatid cyst, or this could also be a fibroma. And the image on the right are the post-contrast images.
Mm-hmm.
So that's a summary here.
Yeah, I like your differential. Could it be? No, I guess a hemangioma wouldn't look like this on the before contrast. It'd probably be higher intensity.
Yeah, you can barely differentiate the mass on the short axis view. You can barely differentiate mass from myocardium, but on the fourth chamber view, kind of like there's a peripheral hypointense rim, you know.
Mm-hmm.
Yeah, which looks like in the same area of intense enhancement. Yeah.
I've seen a hamartoma enhance like that.
Mm-hmm. Okay. Yeah.
But I'd want to rule out a MET for sure. That would be 1, 2, and 3.
So would you guys recommend anything for that? Because I didn't want to recommend any biopsy at this point. I just wanted to make sure if we have to recommend anything for the next step at this point. I don't want to expose a patient to maybe unnecessary
Risk.
Like biopsy, you know.
Yeah. So patient's 80-year-old, so I don't know how much more they're gonna do, you know, in general.
Yeah.
Do you guys have PET CT?
No, we don't. But we have CT chest and CT abdomen and pelvis, which showed, I mean, negative, and we have MRI brain as well. So there is no any of malignancy, whether primary or secondary.
Then I'd probably recommend follow-up, and then if it grows, then you're stuck and you have to biopsy.
Yeah.
Okay, that sounds good plan. Okay. Yeah, I think
Nice
we just
case.
have one case, but yeah, absolutely, I have more than one case, but not for today. I'm gonna prepare those cases, so
No,
I can present it.
Thank you for participating, and please get back to us. Give us some follow-up once you guys
yeah, absolutely
have some pathology if you do, or if it changes. These are very nice images. Thank you for sharing.
Yeah, sure.
Hey, quick question, Oz. Did you do perfusion imaging on the case, and how did it enhance on perfusion? Because I do agree with Jacoba. I think to me it looks like a fibroma, just in how it's showing delayed enhancement, and it's not a hemangioma because it's pretty dark on the SSF images, or even which you would expect it to be bright on SSFP imaging. So to me, fibroma seems like the best bet. I would agree.
Yeah, so so it's like slowly enhancing, and it's more intense enhancement. More intense enhancement on the delayed images.
So it didn't take up. It was not very vascular, right? It kind of
no,
didn't.
it's not. It's not very vascular on perfusion images. Yeah.
Interesting.
Can you guys see my screen?
Yes, we can, ma'am.
Yes.
Okay. Okay, so I really didn't get a chance to get this really together. So this is a 54-year-old man that presented to us on April 15th. He had a 2-week history of increasing shortness of breath, a bit of chest pain, and lower limb edema to the knees, and abdominal bloating. He had 2 transthoracic echoes that showed a moderate-sized pericardial effusion and was treated for pericarditis until he had a PE scan out at a peripheral hospital. All of this took place. So this is his PE scan at presentation. It's not exactly subtle. So what are you guys seeing? Anybody want to give it a whirl?
So there's a very large right-sided cardiac mass. It looks like it's originating from the artery wall, but I guess I couldn't tell exactly if it's ventricular or atrial just from that really quick. No, I'm sorry. And then I guess as you were going further caudal, I guess I'm not sure if that's maybe tumor extension into the IVC right there.
Yeah, it's kind of a flat kind of level almost, isn't it?
Yes.
So I forget what that sign is called, but I think he was quite hypotensive by this time. Does anyone remember what that sign is? It's like that impending death sign.
Yeah, the patient is not doing too well sign.
No, not very well. Is there anything else you see in the abdomen? Here.
Bilateral suprarenal nodules or masses. I don't know.
Yeah.
Density, but it's not doesn't look like adenomas. So
No, very soft tissue, that's for sure. So, so what's the differential for a right-sided cardiac mass?
I was thinking in angiosarcoma of the coronary artery could be, also a mets from the lung cancer.
Yeah, those are 2 really excellent differentials. And there's one other to add. Does anyone know what that third one can be?
Metastasis.
For sure, metastases. With the adrenals, you'd almost think of a lung cancer. Sorry, someone said something?
Lymphoma can present, but it's rare, but the lesion seems like multifocal, so it's rare, but lymphoma can rarely be there.
Yeah, okay. Those are certainly the 3 that that I would mention. You got
Carol,
them all.
Quick
So
question: do we see the right corner? Or is it completely obliterated?
Well,
usually
it's the wrong phase, but it's you can see it.
oh, right there.
Okay, I'll just get my pointer going. No, that's not what I wanted. Okay.
Sorry, what was the second point in the differential? I just missed that. So it was angiosarcoma, mets.
Metastases. Yeah, so there's the origin of the right coronary. If you can see my pointer, and then you kind of it disappears inside the mass. I think most of the contrast is going into that's the coronary sinus there. Like there's no contrast in the aorta, so it's not the right phase to opacify the coronary arteries, but it's likely buried inside that large mass. So he was, put in an ambulance. He was about 50 kilometers away and transferred to the Heart Institute here, and went immediately to the cath lab where they tried to biopsy this and debulk it to improve his chance of survival. So then he had a second CT the day after, the morning after, and this is the CT here. And they wanted us to let them know if they were successful in increasing the flow to the right ventricle. Unfortunately, I can't window this, but so did anyone see anything that happened during the procedure?
A pulmonary embolism.
Yeah, probably tumor emboli. So he's got new bilateral filling defects in the pulmonary arteries. They did manage to open it up a little bit at the bottom here. There's a bit more flow, but not very much. And then you can see again the adrenal masses. And also in the stomach, there's some thickening along the lateral wall there. He actually had that persist on both CTs, and then he had a CT of the abdomen and it persisted too. So, I mean, it doesn't change the differential, and he unfortunately passed away. And this turned out to be a diffuse large B-cell lymphoma. So it's good that you added that last one as a differential, because that's what that turned out to be. And so for right-sided cardiac tumors, often in the AV groove like this and growing into the RA and RV, you have to think about those three. And for not really primary, lymphoma is not primary, but it's one that tends to, for some reason, affect the right heart. And I suppose affecting other organs. I have not seen angiosarcomas metastasize to other areas except maybe the lungs before patients die, but I've only got an N of maybe 4. I don't know what others have seen with angiosarcomas, if they might go to the adrenal glands, and I'm not sure.
I agree with you. I don't recall seeing them go to below the diaphragm. Carol, 2 quick questions. Was he just not responsive to chemo, or chemo was never tried? Because usually they do respond fairly well to chemo.
I know. Well, the worry was that I guess he would exsanguinate because they can often shrink really, really quickly.
Yeah.
But he was transferred Thursday night. He had his biopsies overnight, like at 3 or 4 a.m. We did the follow-up CT in the morning, and then they still didn't have a diagnosis until Monday morning. And I think they decided that it was, I think he just got too sick by that time. He'd just been too long.
Second quick question, coronary sinus. Is there also a small tumor thrombus there in the coronary sinus?
It looks like it. Yeah, very good pick up there. It looks like there's a little something right here, eh?
Yeah.
It's growing, into the interatrial septum here as well, and maybe around the bottom of the LA It's quite thick walled, so definitely I think I see that on the prior scan too. So
Gnarly.
yeah.
All right. Well, thanks for sharing. Any comments or questions about the case, guys? All right, Carol, thank you so much.
You're welcome.
Anybody else
You can.
wants to show a case or share some comments? Going once, going twice.
Okay, Jacobo, I have
There you
here
go.
something very little.
There you go. I'm gonna make you
Okay.
presenter, Julia. Thank you so much. All right.
Okay.
I just send you the invite to present.
Okay. How can I do it? I don't know. Let's see. I don't know. Let's see.
You should have gotten an invite to present, and you just need to accept it.
Okay, but I don't get the invitation, seems to me. Let's see.
Let me try it again.
Okay.
Let me try to send it again. All right, so I took it away from you, and now I'm gonna send it to you again.
Oh, the program give me an advice, and I need to restart the program to show and do the changes in
Got it.
the
Yeah, we've had
window.
that before.
Sorry.
Okay, we'll save it for next time, and we'll try to make it happen. We can actually we'll work on that offline. Perfect. Anybody else? All right, so we'll stop just a few minutes before 5 o'clock. But I want to thank everybody
I
for
can show the
joining.
chest X-ray.
Yes, please. Let's see.
You'll be amazed. Do you want to see the chest X-ray on the guy I just showed?
Yes. We can see your screen, and of course, right? It's gonna look like nothing's going on.
Nothing. This was 3 days before April 12th. There is nothing. And you know, they when they did the transthoracic echo, they just saw, I guess this was really hypoechoic, and they mistook it as a large pericardial effusion instead of
That
like
large.
I don't know where they saw the right ventricle. But anyway, yeah, it's so deceiving.
Yep. That's why X-rays scare me. I don't see half the stuff that then we see in the follow-up CTs, and it's just anyway. All right, perfect. Thank you so much, Carol. So thank you everyone for joining. Thank you for preparing cases, for sharing your thoughts, participating, everyone. Looking forward to seeing you next month for another session. We'll be posting this video on the NASCI website, so you can tell your friends that use some really cool cases to go check out our library of cases, and you yourself can go check out prior sessions. They're all there in the depository. So have a fantastic rest of the week, everyone. And tomorrow, for all my fellow Mexicans, happy Cinco de Mayo. And don't drink and drive. Take care, guys.
Thank you very much.
Thank you. I think I have a colleague of mine here, Anuj. I want to thank him for dropping by.
Awesome. Thank you.
No problem. It's always a good learning.
Perfect.
I'll try to prepare something for next time.
Have you been
All
here
right.
before?